you could command.
Boy,
You didn't even gather.
sure got quiet in here. Thank y'all very much for being here. Welcome this afternoon to the JPS Health Network Board. I'm happy to say, again, we had a unanimous group last month. I appreciate the board, and I know you got busy schedules. Amanda called me. She's actually out of state, and she's being recognized at a very, very influential recognition, so she needed to be there, but she did call me. So, again, appreciate everybody's attendance. While we're talking about attendance, as I look out there, I see Commissioner Devin Allen here. Commissioner, thank you so very much for taking your time to be here. DT will behave today. We're just commenting how, he's all dressed up over here, but yeah, now, as Mr. Zimmerman said, now we know, but we don't have a chance to tell you this a lot, and I know I get to see you. I know Robert sees you a lot downtown at Commissioner's Court, and I do too periodically, but at the end of the day, also your staff is always here, and we appreciate them being here, and anytime you need anything, please reach out to us. But thank you for what you do. That being said, we will now ask the Reverend Miss Leanne Franklin if she would come up and lead us in the invocation. If you'd join me in the Pledge of Allegiance, we will start the agenda. Leanne.
Thank you. Happy to be here. I always try to bring a little bit of the vibe of the hospital, what's going on in the day. And this morning I had the privilege of sitting in with other leaders as we heard Mr. Early speak. And you don't know I'm going to do this, but your words just really impacted me this morning. Again, there's no shortage of bad news. We turn on the radio, the TVs, internet, bad news all around. And I really appreciate what you said this morning, Mr. Early, that our news at JPS is the news in our hearts, and our news is in our deeds. And I just thought that was such a centering message, because that's true. So with that, I invite us to pray. Holy One, we ask that you inform and unite our hearts, that you inform and unite our minds, and that you inform and unite our spirits, so that together we can best serve this entire community that you have entrusted to our care. It's with humility and gratitude that we pray. Amen.
Again, thank you.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Right when Leanne said your words were very inspirational, I heard all this loud. We had to get up and close the door. I won't bring that up. But anyway, thank you very much. Leanne, what I was saying is appreciate your nice comments, but I did tell Robert right when you said those inspirational words, we heard a bunch of laughter in the hall. We had to get up and close the doors. It had no reflection on what your comments were. But thank you so very, very much. The next item is any citizens wishing to speak. I'm told there is none by Mr. Rule, so thank you very much, which will take us down to agenda item number 4, which is the approval of the minutes, which have been provided previously. The May 9th minutes are attached. If there's any recommended changes or any discussion, we'll discuss it this time. If not, I'd entertain a motion. Have a motion. Have a second. Mr. Zimmerman, all those in favor say aye. Aye. Opposed, no. Thank you. This is the point of the agenda each month. I think over the last few months, I've talked about all the outstanding things we've done here at JPS. As chair, I have the pleasure of serving in this chair for a certain timeline. And again, I get to attend a lot of functions representing you as a board in this institution. Last Friday was no exception. Many in this room attended the research symposium we had on behalf of JPS. It was a record year. And I have to ask, I did not see her. Is Dr. Elliott here? Is Dr. Oh, there you are. Dr. Elliott, stand up. Everybody knows you, but what you did, you and your staff, I mean, this was a full day. Y'all did an unbelievable presentation. I have to tell you, there's no question. We had national speakers. We had, I guess, the largest participation. Moved the venue. Many of the board members had been in the past. Ralph, you'd been down at TCC. We moved over the seminary to that larger room, made a great presentation, had a nationally known author come in. But more important, God, this is where you take pride in our people. It was so impressive to see the staff and everything be there. Certainly, I hate following Robert on the podium in the mornings because he's so good, but it was a pleasure to be there. The only point I'll say is this, and I made that comment that morning. I actually made it a point to have breakfast with some of our residents. There was a table of them there, and they made a presentation. And, you know, sometimes things just come to you, and it made me think today, because I have two of them laying here. You know, there's several former chairs on this board that have been in this position before, and we do a lot of things. There's obviously future chairs sitting on this board. But at the end of the day, I was taken back, and I made the comment then, I'll say it again. We attend a lot of functions. We can talk about the bond package, which seems like it was light years away. It was last November, and we think of all the time and energy put into that. And we get all excited about the bricks and the sticks and the future things. But the real mission of JPS is what the people in this hospital do every day across this entire district. The Charlie Powells come and go. But one of the things I told the students that morning was that one of the things I get to do is sign diplomas. And I don't know the names, he or she, but I know this. They have spent their time in our residency programs, and they've been a part of the JPS culture, and they can go out and change the world. They can go out and save lives. They can go out and hopefully find a cure for whatever that helps my grandchildren one of these days. So I'm just saying is that, you know, sometimes you have to stop and reflect on where you are. So to the board, I say thank you for all you do. And again, I have the privilege of, I've been in doctor's offices for many years, and I've always seen all those diplomas on the wall. I was like, who in the hell signed those things? And then I realized there's a responsibility that I have to sign these. But I'm not signing these on behalf of me. I'm signing these on behalf of John Peter Smith. So again, I say thank you very much. Tricia, it was a tremendous all day. I'll let Robert, he's probably going to expound a bit more, but that's kind of my report, Robert, for the board. Thank you all very much.
Thank you, Mr. Chair, and I appreciate that. And for those of you who attended research symposiums in the past, thank you. Thank you for your participation, and thank you, Mr. Powell, for being there. They're eye-opening. As Charlie mentioned, sometimes you can look at those posters and you need an iPhone with you so that you can look up the words that are on the posters because they're challenging at best. And I have to apologize to the right side of the audience. I have new contacts in, so I can't see any of you. I am just looking at you all over here. My right eye is totally gone. I don't know where that contact came from. But yeah, no, not in color.
Okay, I just want to make sure I knew you.
Everybody's still, for me, it's all black and white.
Just want to make sure.
But y'all can do whatever you want. I can't see you. So all staff is moving to that side. But I wanted to let you know that the research symposium had a very nice element to it. We had more posters presented than we've ever had. The keynote speakers that we had national recognition. And when you start talking about the war on poverty and what we're trying to do to supplement that and what we try to do to health, you got to think about where people are living and what they're living with. As opposed to just doing this. You have to understand their environment and their circumstances. You got to understand if you put a clinic that's 2 miles away from somebody, it may be a short distance for you and I, but if you don't have transportation or you have problems with your mobility, 2 miles is the same as 30 miles. So we need to think about that, and there was a lot in that research that talked about that. The three major winners that we had were Kathy Shum, and Kathy presented from the University of North Texas Health Science Center. She was our first place winner. Miranda Wang, who is part of our family medicine program, was our second place finisher. And Travis Motley and his crew in podiatry had the third place finish. And so we had some really outstanding posters with outstanding presentations. Also in Dr. Elliott's bailiwick and purview is, as she says, the circle of life continues, and the circle of life means 76 new incoming residents coming to JPS. For those of you who feel strongly that they look like they're 14 years old, I won't tell you that they are not, but you may be getting slightly older, because when I walk down the hall and I look at them, I think, can he be here or can she be here? But it's me, as Dr. Weber reminded me, my hair is grayer. But we have 76 wonderful, talented, gifted, but yet bright-eyed people who are going through a process at JPS on how to onboard. And we, Tricia Elliott and her team and her colleagues in the peer education side of things, are teaching folks that whether you're an intern, whether you're a resident, or whether you're here at JPS for a month or 6 months, there's a way to treat a patient. And how you treat them here is how you're going to treat them in any practice you go for the rest of your future. And Steve certainly knows that for what you did here, and hopefully what you gained here has been of significant help and impact to you in your private practice, and we hope that that's led to some of your immeasurable success, which we appreciate, and all the teaching that Dr. Weber did as well, and that power. So that was a wonderful situation. We also have another form of interns and fellows that are here. We have our administrative interns and fellows, and these are important folks to us because we started that program, Bill, about 8 years ago, and I had gone to the University of North Texas Health Science Center and gave a speech, and a young lady came up and said, I want to intern at JPS, and that really was the beginning of that program. And we have had incredible interns and fellows come out of that program, many of which have then gone on to work at JPS. And so if Deborah and Zach and Guadalupe and Bertha could stand up, I would appreciate it, because you all are our incoming class of talented people. Thank you all so very, very much. Thank you for being here. You will see a whole lot more of those. Bertha, as a matter of fact, Bertha Kim hasn't even started yet, and she's coming to this meeting, which I'm grateful for. And the others have already gotten into the mix of things, and we've already seen their talent. They go through a pretty rigorous interview process, and we get a lot of applicants into JPS that come from not only the local base, but other places. So I'm proud of them and appreciate what they're doing. Trent and I had a very, I thought, powerful and good meeting. It's the ad hoc committee on sort of the post-bond, and what we're using that is a tool for the court and a tool for the board. It's trying to figure out what we do at the preliminary stages regarding our bond package and where we go. If you hear, where's the bulldozers and where's the buildings? Geez, it's been 7.5 months. Well, what are you guys doing over there? You have $800 million. You should be spending it. And the first thing we have to do is educate the community to know that we're greatly appreciative of the $800 million, but it was not a gift. It's not philanthropic. We would like for that to be the case, but that's a sum of money that we have to pay back. So we have to think about how smart we do that. The second thing is, I will reiterate to everybody, the buildings will last longer than any of us. But you got to put the right things in the building. If you're just building buildings to build them, we can do that really quickly. And this board and this administration can be the legacy of potential failure in the future. And we'll have others in these leadership roles saying, why in 2019 and in 2020 did they make such a dumb mistake? And I don't want to do that. So I want to be really smart with what we do. And that ad hoc committee is trying to deal with putting things together that we can look at not only the building aspect, but the efficiency of what goes in the building. And when you start hard decision-making processes, like what do we do when it comes to a new tower? The easy answer is let's just build a new tower. That tower is old. It's got 3 people per room in some cases. Tear it down and we get that beautiful green space next to us. But should we look at not only what the Blue Ribbon Committee suggested, but should we also look at some form of where healthcare is going in the future? And maybe more beds is not always your answer. We also know that we're at 85 to 90% capacity at all times, so there is an answer. But what do we do to better serve this community? And what do we do from a decentralization standpoint in Arlington or in Saginaw or in Bedford? What do we do, particularly when it deals with psychiatric patients and looking at crisis centers? And those are key questions that we can not only answer, but we can then build to that. And so the ad hoc committee is not a decision-making process. It doesn't do anything. It does some preliminary work so that this board and the court can have better information for the decisions you all are going to have to make and the court's going to have to make. And Commissioner Allen, I'm happy that you're here so that you can kind of see not only what we do, and you know how we do things, and I appreciate your presence here, but also as you go through the process of dealing with the bond and helping us. It's greatly appreciative. And Rebecca, I appreciate you, obviously, in your commission in being there and all that you all bring to the table as we walk through that process. And I do know that there are community interests that says, let's get moving. But we're the ones that have to live by those decisions, and we're the ones that look every day in the eyes of our patients, and we can't let our patients down. So by doing the right thing, we'll have a legacy and something that we can be proud of, and people will look back and say, thank God for that board in 2019, because they made the right decisions. So that's what we're working towards, and we'll continue to work towards that. You all have a document in front of you called the Patient Experience Mastery Program. And the reason that we put that in front of you is we gave you dates and times for a variety of classes that are going to be taking place. You as a board were instrumental in changing the culture of JPS. If you joined the board recently, you are a significant part of that cultural change. If you're Pastor Emerson and Trent Petty and Chuck Weber, who we all got in the room at the same time and tried to figure out what we did to turn the culture of this organization around, you can see empirical data which shows that cultural change. You can see a difference. It is in not only the gray area of a feeling when you walk in the door, it's patient outcomes that you've seen differences in. What we need to now do is take that cultural change we've done with our employees and make that stick from a cultural change from our physicians and that standpoint. So what we've done is we've reached out to many of them through the work of Laura Burnside and Dr. Tim Kramer. And we've put classes together and we've invited physicians to come and talk about what the patient experience is like. Give them the tools to understand. And the reason that we put this together, Laura and Dr. Kramer put this together, is it really does give insights into what we're doing, and it's peer-to-peer discussion. Where I think it's been a challenge is when you talk to employees, it's one thing. When you're talking to physicians, I think it goes best when it's a peer-to-peer discussion, because that physician can turn to that other physician and say, he doesn't know he's not in a clinic. He doesn't know he's not in the OR, and it is a different world. So I think we can have the principles and the philosophy, but until it's espoused by folks like Rob Stevenson, or it's espoused by Michael Hochberg, or it's espoused by Karen Duncan, it's not going to take root. So these are classes that you all are welcome to attend, listen in on, and listen to what our doctors not only are hearing, but what we're getting from the interaction from our doctors. This really leads into a growth of what we created at TCU with the educational programs we're doing at TCU, and that program will now be elevated. We are now on our 4th cohort at TCU. And what we do with that program is we have anywhere between 12 and 18 physicians. Chet was part of that program. And we bring our physicians in and give them tools by which they understand how a budget is formed. We give them tools about what your patient SAT scores mean, as opposed to just saying, well, we can't achieve that. It's a public hospital. It's a different world. People didn't even speak the language I spoke. Or why would you do a pre-op huddle or a post-op huddle? Those kind of things have been really important in that TCU program. So now what we're going to do is we're going to create a program, and we've had Chet and Tricia Elliott and Tim Kramer and Michael Hochberg help with this, is now we want a program that gives you class credit and a certificate. And the class credit would go if you ultimately want to take an MBA or you want to get an advanced degree, and it goes for certification in an advanced program. And it will really look at a deep dive into sort of the social patterns of our patient base. It will look at how one does create a budget. It will look at value add to services you provide. So I'm really proud of Tim and Laura for putting this together, and it really kind of goes in with what Tricia Elliott and others are trying to do from an educational standpoint to advance, because we will have an entire network of people all moving in the same cultural direction, and that is a complete dedication to your patients, because when you do that, everything else falls in line, everything. So
who's your target audience? Is it the house staff? Is it everybody?
it's everybody. Yeah, it's everybody from a medical standpoint, and we're branching out as much as we can to everybody that sees the patient in a medical sense, and it's all encompassing. So again, I put this in front of y'all so that you all can consider attending that. And I think, unless you all have any questions, Scott, did I forget anything? Thank you for saying that. If
Good
there's,
job, Scott.
if there's anything else y'all have from a standpoint of questions, I'm happy to answer those, but that's all I have, Mr. Chair.
Good. Yes, Ralph.
Yeah, I'm gonna go back to Robert's other report on the ad hoc committee. Because one of my concerns is, as the ad hoc committee meets, that, you know, the hot issue now is behavioral health. I mean, just,
Right.
okay. But I would hope that we would look at what's driving our culture and what the culture is driving healthcare, so that by the time we get ready to lay out that plan, we see what's driving healthcare at this moment. It may not be behavioral health. And I hate for us to get down the road and we build 10 behavioral health facilities, but we need a bed tower or we needed clinics. So I just hope, what I see is that it's almost like another re-education to the John Q. public
Right.
on where we're going. And I don't know how we piece that together, but I think it might mean some more town hall meetings to look at that and address those situations.
I agree, and I would add another dimension to that, and that is we have to look at not only the buzzwords of healthcare, but what kind of situation do we want for the patient base of Tarrant County?
Yeah.
And what are we doing? Because the patient base of Tarrant County may be different than 30 miles away in Dallas County, quite frankly. It's a different world, and you can't just take examples of what they're doing in Oshkosh, Wisconsin, and put it in here. It's a different set of circumstances, from transportation to social economics to mores and everything else. The other thing, Pastor, that you all as a board and we as staff are going to have a challenge with, and that is great ideas and the money behind that to pay for those great ideas. And I think that's where we need to educate the public, because the public's going to say, why don't you do this? Or my daughter needs this service, or my husband, because we become fairly myopic, and I understand that, but we also have to look at how we pay for things. And so what our intention as staff is to present you every plan, why it has that priority, what we want to do, and how we devise ways to pay for it. So you, as board members, are going to have to stretch yourself, in some cases, to a level of slight uncomfortability to help pay for that, because the trees that we planted that we thought were money trees, they haven't yet produced the money. We went out to the leaves and we found out there's not dollar bills on them. And we keep looking for the rainbow and we can't get to the end of it. So we have to figure out how we have a component financially as well, because that would be a nightmare to build the building and not subscribe to and keep to the vow that we and the court made to not raise taxes. And at the same time, we need to be efficient at looking at new models coming in. So your point's well taken.
I just want to add that in attending the American Hospital Association board meeting, one of the big things was what's moving throughout the country is the clinics that are being set up in CVS.
Right.
So when you look at that, how does that impact us and our neighborhood clinics?
Right.
You know, so I think as we look at all of that, I think it would be crucial as we, you know, put together our plan.
We have discussions, Pastor, that the largest provider of healthcare services, one could argue, could be Walmart in 5 years,
Right.
or Amazon.
Right.
And those were not discussions we had 5 years ago.
Right.
So the changing climate of healthcare and its delivery, and the fact that Walmart's taking the action it is not only worthy of our attention, but it could change, and they could not be the player that they want to be, and we need to be cautious. But I do sincerely want to thank Trent for what he does from the standpoint of representing you as a board and as chair of planning, because his insight and development is hugely helpful in the room, just as many of you have insights. If I've got questions on some of the internal mechanisms, Dorothy's helpful. If I need to reach out to the community, I'm going to turn to Ralph and say, tell me what we've got on that particular area so I can do that. Every one of you bring a specialty to this board, and it is helpful because, one, as you all know, Trent is not bashful, so he doesn't really care who's in the room. He'll ask any question. And were you asking if that was a compliment? It actually is. And so it's helpful to have that, and it's helpful to have all y'all. So when we bring ideas back, they won't be decided at all. They'll just have a little bit of vetting so that you all can then take it from there.
Yeah, that's the point I wanted to make, Robert. I think because of the time that's elapsed, I think it's easy to assume that, decisions are being made. And in reality, what we're really trying to do is agree on the broad perspectives that we have to follow as those decisions are made. And one of those is, as we talk about deployment of capital, then deployment of capital becomes a critical issue, not just in terms of which buildings we build, but what operational offsets we receive as a result of revenue streams. And that's where I think our board is going to have some exciting and maybe difficult decisions to make over the next 2 years relative to things like lines of service and revenue streams that we have in the past not been able to access. Because honestly, I think deployment of capital, our biggest constraint is how we come up with revenues to support those deployments of capital.
Right.
And if we can move sort of our perspective from the lines of service that we've been used to forever to brand-new ideas about alternative revenue, then we have a better opportunity to deploy that capital quicker. And everybody wants to deploy it quickly. We've talked a lot about maybe it's wise to do some of the clinic stuff at the very beginning and make it concurrent with some of the behavioral health things.
Right.
Those things allow, there are some revenue streams to do that. The other thing we've talked about is, as we look at the clinics, we have a wonderful model now in Euless. And the fact that we've got a population health program now being deployed there gives us a very good template that we're not going to have to go and reinvent every wheel as we build those new community clinics. So we're trying to make certain that we have the right platforms to sort of leap off of on these things. No decisions are being made. The biggest decision right now is where we put the professionals in this process to manage project, but even more importantly, how do we manage these platforms? Because they're so big and they're so large and they cover so much time that we just can't dive into this and say, okay, let's hire a project manager and start X. We've got to know that we've looked at it from the perspective of, if we deploy this, what's the revenue going to look like associated with that? What are the new expenses associated with it? Because when we do come back to you all with recommendations, we need them to be responsible. We need to be recommendations that don't result in us having to go ask commissioners for a tax increase in the second year of our deployment of capital. So it's frustrating because there's a lot of time that's elapsing. It's frustrating to me, but it's necessary, and we are making progress, and I want to be diligent to try to report back as frequently as we can. The meetings are productive, but it's slower than I'd hoped. So we're on our way, though.
You notice that Trent replaced Northeast DT with, Southeast with Northeast.
That's the way it goes. Do what you gotta do.
Thank you, Trent. Robert, do you have anything else?
No, sir, that's all I've got.
Trent, Robert said it, and while we're talking about thank yous, how much I appreciate when I became chairman almost 3 years ago. I remember Trent and I had a conversation. He said, well, I guess I'll be coming off. I said, what? No, you'll be staying on. That was long before we passed the $800 million bond package. So I appreciate all your work, Trent. And with the commissioner sitting here, I know there's 2 commissioners that currently serve in those discussions because we're trying to keep that parallel. And I think one thing we need to make sure transparency is all of us move around the community. We have some guests here today that approached us before, and I know they get tired of us hearing we can't say anything. Truth is, we don't know anything. It doesn't sound right, but till we really formulate what we're going to do, the worst thing we could do to get out in the public and then change. And so I appreciate all the time that you, Robert, I know Judge, I know Commissioner Brooke, I know there's some people involved in that. So thank y'all for the continued. And the main thing is we say along from a transparency standpoint, Trent, we probably will start expecting more and more updates on kind of where that's going. Dorothy?
I just would like to ask, I know Trent is working on it, but maybe it'll happen at planning that we could spend a little bit more time getting some of the board's ideas or some of the things that they see and make sure that we're all trying to get to that same place. Because as you bring it back, we're going to have it where all of us are kind of sitting and talking about it a little bit more, okay?
And Dorothy, that's an excellent idea. That's why we had Trent. I mean, Trent chairs planning, so I think it's a great place to do that. Also, I mean, I know even search external things that affect it. We had to wait till the recent, what happened in Austin on cap rates. I mean, it's not just to go spend $800 million. How are we going to pay for it? We didn't know how we were going to be affected by what was going to be passed in Austin, Texas. So, you know, did we come back to everybody and say, oh my gosh, till they make their mind up what they're going to do in Austin, how are we going to be affected? Because we got to pay for these. I mean, just because we issue the bonds, we got to pay for them. So there's a lot of that external stuff, but I think you're exactly right, Dorothy. Hopefully they can come back pretty soon and say, okay, these are kind of what we think, and then we can say, well, here's kind of some of the thoughts. So that was the idea behind this.
And at
We
this
got to
point,
start someplace.
you're right, and at this point, Dorothy, what has taken place is a very high-level discussion about not projects, not ideas, what type of external source
Yeah.
do we need to help us manage this? Do you need a traditional project manager, somebody that just says, here's what you need to build and here's the time frame in which you need to build it? I would argue, no. You need more of a circle of care that looks at the efficiency model, that looks at the financials of it, that looks at our patient, and then figures out that future gray area that says, the Blue Ribbon Committee suggested 4 clinics, but we think actually 6 is better. But they're better in these locations, and you're going to put 2 that are going to be here and 1 that's, as opposed to, let's separate the county in 4 quadrants and go from there. That's never good, and that's never a good thing for us, even though there may be a vacant lot or there may have been an area that would look really nice if we could revitalize so-and-so's grocery store. So that's where it's been. The other thing, to Charlie's point, even though Leanne did not pray for them, she sure could have, because the legislature was hugely helpful to us. And we want to thank them very, very much. We want to thank them for 2 things. One, they concluded their session, and we're very proud of them for doing that. And we want to thank the Senate members and our delegation of Senate members that pushed hard for us in keeping our property taxes the way they are, and Speaker Bonin, who steadfast stuck to that rule, but there were a lot of members of our delegation that never turned their back on JPS and fought from day one, and that's why we were one of the few that were able to do that, because to Charlie's point, if they had capped our property taxes, there truly would not be a bond initiative, because we could not have afforded it. As Sharon estimated, anywhere between $6 million to $15 million of an impact to us, and that would have been in perpetuity. So I want to thank the legislature, and we're thinking about what we do. It's going to be hard to invite them all up here to have a day to thank them, but we were looking at taking a few of those key members and bringing them up and having a celebration of thanks, because they were hugely helpful to us.
Thank you, Robert. All right, next item on the agenda is item number 7. Dr. Schrader, Chet?
Yeah, so, thank you, Mr. Chair. I'll be brief, and probably so brief that if Dr. Hochberg wanted to start his slow walk.
Michael, you may start coming this way.
He's welcome to.
Yeah, start.
Well, if you want to start the slow walk, you're welcome to, because this should be pretty short. In your packet, there is a request for a delineation of privileges for what is known as preventative medicine, and we're going to place it under the Department of Family Medicine. Preventative medicine is a recognized specialty by the American Board of Medical Specialties. We have not since had or previously had a member of that specialty request to be on our medical staff, but it is a board-designated specialty that focuses on population health. A lot of individuals that pursue this specialty work in public health domains, such as health departments. In this instance, the individual who is going to be applying for that privilege is interested in working in with our jail population. So in it, you'll see the various criteria, including the completion of said residency and the core privileges they'd be afforded.
Any questions for Dr. Schrader? If not, I'd entertain. Mr. Montgomery just said he made a motion. Second by Mrs. DeBose. All those in favor say aye. Opposed? Chad, anything else? Thank you.
Yes, sir.
Thank you
That's it.
very
Thank you.
much. Michael, come on up. Dr. Schrader, come. You timed. That's right. You had to stop and lean on the pole. Come on up.
Fastest I've seen you walk. There we go. No, just kidding.
If you would,
He saunters.
yeah.
Thank you, for everybody. Just a few brief updates, and ironically, they touch upon some of the questions that have already been asked or updates that have already been issued. On the resident side, So Acclaim is very proud to announce that we have hired 11 of our graduating residents for this coming year past their graduation. A few of those are PRN hires as needed, but the majority are as full-time providers. 7 of them are in family medicine, 1 is geriatrics, 1 is OBGYN, and 2 is in psychiatry. And so that is really one of the largest pushes and recruitments that we've had of our graduating residents. And so a real big effort working with Dr. Elliott and across our service lines to ensure that we retain the folks that we train here as they continue to give back to our community. Other items on the recruitment side, we are very pleased that we have completed the recruitment of our second vascular surgeon. This has been a long road, and that has now been finalized. That individual will be starting in and around November, December. The first one comes in September, and so that'll significantly benefit our patient population as well. We are in the process, in talking with regards to surgery, in the process of doing a recruitment for a surgical oncologist. This ties directly to the opening of the Oncology and Infusion Center to have an individual who would serve as our medical director for surgical oncology and provide overarching vision to begin to grow and ensure that there is close collaboration across the services for some of our most vulnerable patient populations. We have also just finalized our recruitment and hiring of our Director of CMS Innovations and Value-Based Care. This is a position that ties back to really looking again at delivery mechanisms. And this is something that, as the board has already discussed, that is going to be critical moving forward, is understanding how we provide care, the vehicles and forms in which we provide care, and that's not just on the outpatient side, it's looking at the entire continuum, outpatient, inpatient, and post-acute services. And this is something that I have deeply challenged all our providers and individuals across the network to really understand what do we do, how do we do it, and can we do it better? And so this individual, her name is Novella Tasco. She's got experience at Deloitte as a consultant. She worked at Bon Secours in Maryland, and so really brings an understanding in and around population health and a variety of other avenues. So a successful couple of months on the recruitment end, and more things to come.
Any questions for Dr. Osborne?
I'd say congratulations
On hire, yes.
on how far they've come on doing what they're doing.
And great hires, too.
Great, thank
Other
you.
questions? Thank you so very much.
Thank you, Michael.
Next items is the committee reports, and the first is finance, and I know he's going to tell us he did an outstanding job because I was at the finance committee.
Well,
But
I'm not
I'll
going to
turn
say
over
it,
Chairman.
but some people have said it might be the best finance
Yeah,
committee.
it may have been the
ever
best
in Tarrant
finance meeting
County.
ever. As a former finance,
I'm not saying that, but
as a
it's
former
been
finance
said.
chair, I would tell you it's certainly a lot better than anything I'd ever done. So anyway,
You know, the funny thing is,
I
even though
totally-
I can't see that side of the audience, some of them are actually thinking you're being truthful. They're like, really? Does he think that?
That's how the audience laughing.
Yeah. The staff side.
yeah.
Yeah.
What y'all have done is y'all have embarrassed me in front of the commissioner. She has seen me lose total control of this board just like that. So,
Yeah, well.
Anyway, Chairman Montgomery, do you have anything else for the finance? before we-
I'd like to just quickly state, we did have a finance committee meeting on the 25th of May, 23rd of May, or 5th, or something like that. And I did want to report that and a lot of folks were already here, or for that meeting, our numbers are looking really good. And I want to commend administration and the entire organization for really scrutinizing the budget and really running a fine operation, because our numbers are looking really good year to date financially, and I applaud the administration for that. And there's several contracts on the agenda for consent for your consideration. And Sharon's here to review the April numbers.
Great.
Yep. So as Steve had mentioned, we had a really strong month in April.
Admissions, ED, clinic volume, all of that was up by 7 to 8% relative to the budget plan. You can see that when you look down for the medical center, we ended the month at $4.1 million compared to an $850,000 budget. So again, mainly due to strong revenue this month. We were about $2 million ahead of our top side, and good expense control. We were about $1 million under in some of our expenses. When you look at the acclaim side, they ended their month with a $2.2 million loss, just slightly ahead of their budget. As a reminder, we had kind of a year-to-date adjustment for 2 new service lines that had come forward this year. So we were estimating a percent of charge that we would collect, and now that we have 6 months' worth of information, we were able to readjust. So when you look at a consolidated view, we had about a $2 million month compared to a budgeted loss of $922,000. This has not been an unusual month year to date. We continue, if you look at the 7 months ended April, about a $14.3 million income from the medical center, or about $9.5 million ahead of budget. Again, expense control has been the key this year. In a claim, they have exceeded their budget expectation by about $1.4 million. So when you look at consolidated, and again, I can't draw on that piece, but you can see just over to the right, it's $2.3 million in the black from operations. We had budgeted this year to be $8.8 million. So to me, that's a true success. Last year's budget was very difficult, as a lot of you remember. Fiscal year 18 was a difficult year financially for JPS for several different reasons. But year-to-date, our net income is $13.7 million. Covered that really quickly at this meeting, but does anyone have any questions that I could answer?
Any questions for Sharon?
Okay, thank you.
Yes, sir.
I just want to comment that I think that Sharon and Robert and staff, Bill, something that Steve mentioned, has done an outstanding job when you consider all of the surprises that we've encountered this year, from the elevators to the and we're still functioning and it's going well. I think, matter of fact, I want to personally compliment Steve, who heads the finance committee. But I just think it's commendable to get that kind of report based on all we've had to encounter this morning.
Ralph, your point's well made, and we're going to deal with those elevators here in a moment on the agenda, as you can see, but those expenses still kind of unexpectedly continue to hit. But you're right, it's been a very good year. I say this personal, under certain laws, we can't use names, but one of my former assistants had a stroke, was rushed to this hospital last week, straight into emergency. Had never been to JPS. She's in late 70s, lived in Fort Worth her entire life, worked downtown at a bank for all those years and retired some years ago. She had a stroke, was rushed in here by her brother, happened to be at the house. I came over and saw her in ICU the next day, and I'm real bad, and Robert gets on to me about this. I know Bill does. I'm supposed to wear my badge when I'm in the hospital. I know that. I don't even have it on day. It's laying on the console of my car. But, you know, when you come and go in the hospital, sometimes people go, oh, they do that. You've been chair rep. Oh, they do that because they want to make sure things are taken care of because you're the chairman or something. Let me tell you something. I was there just like any other visitor in the waiting room, talking to people, talking to family, back in ICU checking. She called me last night. She's now home. I check on her every day. She said, I've never been to JPS. Most unbelievable. She said, I know, I love her to death. She goes, I think you're involved somehow out there. And I said, yes, Glenda, I am. And she said, please tell that staff of people how great they did. I've never been there, never thought to be there, and what they did was amazing. Those are the kind of stories we don't put on billboards, but that happens every day. So Rafi brought up a very good point. Certainly, we need to drive the finances. We just talked about how we can pay for bonds when they're issued. That financial element has got to be a major focus because we have the responsibility to obviously the taxpayers of this district. But more important, we do that other stuff every day, and sometimes, like you say, you can't anticipate everything, nor, as we just talked about Austin, nor can we anticipate what those cutbacks are coming out of Washington. Just a little tweak here doesn't sound like much, and it turns out to be millions of dollars. Anyway, any other questions for Sharon? If not, we will move on. Sharon? Yes, DT. Hit your, yeah, thank you, DT.
It may not help.
Yeah.
I'll try to repeat it.
I'm just going to say the tie was a little tight. Is that-
No,
Look
I'm
at
just
Steve over there.
commenting on the CMI index and the average length of stay. Since the average length of stay goes up a lot more higher,
Yes.
should we be concerned about the coding side of it?
So we have many different people looking at that average length of stay from different angles. I'm happy to report that in May, we've seen a nice reduction of that. There are several different reasons. We've had kind of a unusual amount of long-term discharges from the hospital. So our average length of stay is only calculated on those folks who have discharged. It's the way that the numbers work. And, you know, the inpatient areas are working on average length of stay. It has gone up from last year. But, you know, hopefully this is the beginning of a trend that we are going to see that come back more in line with the budget expectation.
I think I'm not concerned about our documentation. I'm more concerned about is behind the scene with IT.
So,
On the coding side of it, because it may show on your medical record, but it may not translate into your bill to go
So
out.
from the audits that we have done, kind of post-billing through our medical services, I think the largest opportunity that we have is going to be in the actual documentation and actually making sure that what we see on that patient and what we're doing for that patient is in the EMR, the electronic medical record.
No, I think you misunderstood. I'm not saying. I think you guys may want to take a look at from the Epic perspective to make sure that they translate what is the EMR onto the bill, because sometimes they restrict it, and so it's there visually, but it's not there. It won't affect your revenue, but it's going to affect your value-based care as you bring the new person coming in, because it's the perspective coding will be different than the prospective payment.
I will carry that forward.
Yeah, it's not what you guys do, but it's behind the scene that you don't see.
Okay.
That it's nobody's fault, but it could be some IT
And maybe we
matching
can
issue.
talk at a, you know, with some folks at a different level than myself that are really more into.
Because I'm going to see the CMI and
technical
the
side.
length of stay, that's raised a little bit of concern there.
Okay, sounds great, thank you.
Thank you, DT. Any other questions for Sharon? If not, Sharon, thank you so very much. The next item, and obviously, is Human Resources. And Dorothy, I know you had a meeting, and we're going to have a presentation day. Is there anything else before we call Michelle up?
No, we had a wonderful meeting, a lot of discussion and review of our annual and long-term incentive program, but our main deal was our diversity report that we received that will be presented today by Michelle.
Good. And before we bring Michelle up, I just want to say Michelle also participated in the health equity presentations at the symposium. And I have to tell you, I did mention the gentleman's name, and Michelle, you may correct me, I think I wrote it down as Mr. Gerald Johnson. I know he was head of diversity and the health equity for the American Heart. He was a tremendous speaker. And again, we know that those environments play such a huge part. You know, Ralph, you've been so involved with infant mortality, but it was amazing to see the statistics throughout the country, and even broken down into this area, that people who live 2 miles apart, the life expectancy, I mean, we all know that, but when you hear it and you see the impact, he gave a tremendous presentation, along with Michelle, who also was involved. But if you'd come up and As Dorothy said, a great presentation in HR, and I think the board's going to certainly, Dorothy, thank you for arranging this. Robert, do you need to add anything for that? Okay.
Good afternoon.
No.
Wonderful. I am excited to give you an update today on our initiative for diversity and inclusion. Can you guys hear me?
There you go.
Is that better?
That's better.
Wonderful. Excited to see you today and to bring you a quick update from the Office of Diversity and Inclusion, and particularly some of our initiatives. So thank you. I also agree that the research symposium was enlightening.
Great.
And the thing that's really amazing is we're seeing all of our efforts combined into one, whether it's research, diversity and inclusion, patient experience. Today, I'm going to update you on something that we've talked about before. It's a quick update on our efforts to improve patient outcomes. And one of the tasks that we were tasked with about 6 months ago from our executive task force, which is comprised of Pia Walker from Human Resources and Wanda Peoples from our nursing area, Laura Burnside, Dr. Elliott, and Dr. Duncan from Community Health, was to look at diversity and inclusion with a specific focus on how do we improve our patient outcomes. So we understand that diversity and inclusion is important, and we've talked about that as it relates to our employee base and respecting each other and valuing and working as a team. But this initiative really wanted to focus on what can we do to be better with all of our patients? And are there any things that we need to learn or do differently in order to do a great job there? So I'll give you a quick update on what we've been doing. And also we have some metrics, some outcomes that we're already seeing that let us know that we're going in the right direction. So the initiative is called Improving Patient Outcomes Through Cultural Competency. We're calling the first phase Serving with Sensitivity. So with Serving with Sensitivity, we actually determine what areas to focus on through data. There's that research part again. So we had focus groups from a team that included physicians, nurses, community health, human resources, every area, clinical, non-clinical individuals, to say what areas do we need to focus on. With this group, it was determined that there were 6 key areas that we should focus on. The first one was cultural competency. The second one was homelessness awareness. Another one was mental health. And then we also had gender identity, mental health, and end of life also, which we actually had a preview of this morning, and cross-cultural communication language. We have more than 110 languages that are spoken by our patient population, so that was one that was high on the list. So those are the areas that we have initially said, phase 1, let's bring awareness and let's make sure we make education available on those topics. So that's what I'll report on today, and we're excited about the results that we're seeing. The goal of the training and our purpose, you'll see there on the screen, is to develop and communicate shared understanding on how diversity and inclusion are essential factors to facilitate our ability to accomplish our mission. What's really key is everything that we're doing is focused on the mission of JPS. So this is not a separate initiative, separate from our primary purpose of being here. And we're looking at diversity and inclusion as how do we help facilitate transforming healthcare in this Tarrant County community. And so with that, we started with just some basic definitions on cultural competence and our ability to work with people from different cultures. We talked about what is culturally competent care, with a focus on respect of culture, beliefs, literacy, communication needs, and respecting people in general. So we just established, here's what we mean by cultural competency and making sure that we have that clear understanding. All right, we've had 3 sessions reported on the screen, and I want to talk to you a little bit about who's been attending those sessions. The first one was culturally competent care, foundation, definitions, why is it important, who are the cultures we serve, what are their needs, what do our patient satisfaction studies tell us about what their needs are, how can we do better with serving everyone who walks through our door. And then we had gender identity, and then homeless awareness. As you can see, and with just 3 sessions, we've had approximately 300 people who've already attended. This is not mandatory training. We don't go in and make people come into the session. It is a part of our grand rounds, which we already had nursing grand rounds. Diversity grand rounds is lunchtime, so people voluntarily come in and want this information. I think the, yes. Okay, why is it optional? No, that's not a bad question. That's a good question.
Really good question.
That's a really good question. We've started with a couple things, a couple thoughts. Obviously, you can make mandatory training and say everybody has to come. And we have people who come with a ball and chain, and we have to be in training, they made us come. And we're gonna try to get through it. So we really wanted to have an environment where, first of all, that's why we did the focus groups first. Where's the need? Because we believe if there's a real need, everything we're doing is based on our patient needs. If there's a need, then people are going to pull towards that. There are some things that are mandatory. This year, first year, we were able to put compliance training in our CBLs. There's a list of computer-based learning that has to be followed for each employee. And before, we didn't have diversity and inclusion. So things around class standards, culturally, linguistically appropriate services, health services, things around joint commission, requirements for cultural competency, it is mandatory in terms of a CBL. These topics, we wanted to open up for people who had patient populations that they really had to work with, that they needed this information for. The great news is we had more than 100 people attend the session we had on gender identity. We had 65 this week on cross-cultural communication and language. We've had a tremendous amount of people saying, I need this information. I have patients, and I'm not sure what I need to do, or I need more information on how to make sure I am handling things appropriately. You can see we've had physicians attend. Again, it's been open to everyone. Nursing, who are familiar with Grand Rounds, but the nursing group, I'm really excited to say the executive team. You can see that we've had most of the executive team already attend sessions in these areas, and supervisors, managers, and other individuals. So it's a very, very diverse group. We have it in this room, and it's usually full capacity. 1 hour. Our methodology is not just lecture, where we're sitting there going on and on and on. Methodology is simply giving people information, give them stats, talk about our patient population. It's open for question. We have subject matter experts that are here. Dr. Robin McKelvey, we've had Joel Hunt, who was here earlier for the homeless population. They are the speakers. So we have speakers that are working right here at JPS. Yes.
I want to go back to Trent's question. I'll ask Trent why he asked that question.
Well, we had 300, right? We have 5,000 employees for JPS. If it's affecting patient outcomes, and if we're doing it because we expect it to affect patient outcomes, that means we're measuring the effect of this program on patient outcomes.
Yes.
We're not giving ourselves much of a chance to move the dial with 300 out of 5,000. That's my just
Okay.
observation. I want to disagree a little bit. Patient outcomes, a lot of this physician involved, obviously. The house staff and attending physicians are stretched every day further and further and further with mandatory conferences, time dealing with the electronic medical record, things that we didn't have to deal with in the past. So I understand completely where you say make them mandatory.
Well, I'm not saying make them mandatory, I'm just curious.
Well, that's where it eventually gets to when
Yeah.
you say mandatory, somebody's keeping a score, et cetera. I understand the importance, I agree with the importance, but I would ask you to be very sensitive when it comes to mandatory training,
Yeah,
especially for the residents.
Yeah, I was gonna say, if I may, it's part of the same strategy that Mr. Early took with physician engagement, right? And so you've got to start the dialogue in the institution. You've got to have passionate people that are willing to engage their peers. And then at that point, it starts to become a norm. And then you can roll out what a CBL looks like. I thought it was a great question. I actually agree with the concept of the focus groups and the way we're going forward, but
Yes.
if you did it as a CBL and just blanket said, we're gonna ask 6,000 people to read it, I think it's fair to say a majority, if not more, will click through the boxes pretty quick, and it's not achieving what you want to achieve. And so similar to the physician engagement strategy, let's find passionate people that are going to start the dialogue, the message, change the culture of what we expect, and then it starts to become normative.
Yeah.
Yeah, if you get 5 or 10 doctors who go and attend it and say, wow, this is worth it, that trickles down very quickly.
Well, the reason I asked Trent, back to Trent, it was because I knew why he was asking. And I understand what you're saying, Dr. Weber. I agree with that. And I would raise that question, why aren't they asked to come? Okay, but I think that somewhere seed must be planted. And I think that's what's taking place now, that the seed is planted. So if the seed is planted at this spot, then those who receive the seed will do planting in other spots. And so I think it'll move that way. Because I know if you tell me I gotta come, I'm sitting, but I'm not listening.
You're locked down.
You're right. But I think that,
What we found, it is a marathon and not a sprint.
Right.
And so what we're looking at this is not as a program, let's get through 3 months of this and this is over. This is a process, and we have a strategic plan that will go far past just what's happening with this session. But first phase, we're just ecstatic to tell you that individuals are pulling. When we saw individuals come in and no room to sit, again, without any requirements, on their lunch break, and we didn't provide them lunch either, just so you'll know. They came in, yeah, pretty hardcore. But we are looking at the entire approach. We are looking at that. But I do have some good news I want to share with you.
Before you get,
Yes.
can I make a suggestion? Can we find a way so that we can have, because every year we have 15 to 20% turnover. Start with the onboarding first of the new people coming in so that they can start seeing the culture that we have, start them fresh, and then middle management needs to buy into it, and then the rest will spread. Otherwise, it's going to be tough, but I know this is early start, so.
I'm excited to hear your question. The question was, can we do something to start with people when they come in the door, orientation, and can we do something with middle management? And I'm happy to report we're addressing both of those. So we have a orientation that our Organization Development and Learning group puts on through HR, which is a part of our team, and we have a presentation. So each person that comes on hears the vision, the understanding about diversity and inclusion. Most of all, they hear that they're going to be respected and valued as a team member, and that they're welcome here, and that we value their skills and abilities and the different backgrounds that come. So we are firmly in that orientation first phases for the last 3 years, actually. The second part, I attended this morning with Joel Hunt and Leanne Franklin. We're involved in our middle management and our leadership teams, also receiving some of these same modules. So just this morning, Joel Hunt delivered homelessness awareness in the session that Mr. Early opened, and then Leanne Franklin was able to report on end-of-life care to a group of middle management leaders. So again, we're looking at a very comprehensive approach, and this piece is just the first phase of those areas that were identified with the focus groups.
Can you start with us?
Can we start with the board?
Us. Because I think we need some training, especially around the homeless and all that stuff also as well.
We're always available for whatever the board needs, and we'll welcome whatever opportunities there.
Michelle will be happy to train you.
Okay, all right, so let's talk a
I'm one of
little
the
bit
few that
about,
use
I know I just have a
county
couple more minutes
facilities.
left, but. Yeah, I just have a few more minutes left, but I want to go quickly to the results of the training, pre-post, as we look at culturally competent care, the first session. What we really want to measure are we making a difference? It's great that we come and have fun and we listen and have a video, but we're seeing the dial moved in the areas we want to see, the measurements. The first question was understanding how national health standards on culturally, linguistically appropriate services, which are called class standards, understanding what those are. When people came in, they just said they did not know what they were, 41%, and you can see 79% by the end of that session, so almost a 40% increase. I can list in invisible and invisible and visible dimensions of diversity, basic things. Basic, where do we know things that we see in terms of diversity versus things we don't see? So we're seeing the dial moved in those areas. On the next one, you'll see gender identity. You may wonder what were we asking in reference to that. Simple questions, I can communicate and address the needs of a transgender patient or a coworker. I understand that. So again, we see major difference in improvement there. We ask questions, do you have different ways to reduce and overcome barriers to provide quality of care? Real key, what we really focus on, to all patients, key word being all. So no matter what type of patient and you encounter, are you able to provide the best care? And that is really the ultimate goal. And then the last one was homelessness awareness. Again, we saw moving the dial and providing culturally competent care for the homeless community members. And again, we had an excellent presentation and resources on how to do those things. So overall, we're excited. We're ready to go. We said it was a journey. It's a marathon and not a sprint. So we have completed the first couple laps, I would say, and then we're moving forward. We're ready for mental health awareness, July 17th. Excellent group of leaders from mental health, behavioral health will talk to us about mental health and what we need to know. And then patient care, end of life with Leanne Franklin also will be August 21st. We're also on the road as requested. So if a clinic says we need help with this area, can you come and share this? We have a collaboration that does that. And I mentioned earlier that we're working with our leaders in our LAP program. I think the real success of what we've seen is the integration and the fact that this is not a diversity and inclusion project. It is a project in which, as organizationally, we've connected. So we're not an island. We didn't say, how can we create our own plan? We said, how can we get involved with what's already happening? How do we get involved with orientation? How do we get involved with our LAP program? So we didn't create a lot of new programs. We simply integrated information because it's all connected together in the ultimate goal of improving our patient outcomes. And that's it. Do you guys have any questions?
I just want to mention one thing, Michelle. Again, and I somewhat spoke to this at I think HR at the last board meeting. When you look at your presentation, which excellent, thank you. This also impacts where Robert and Trent are in that ad hoc committee as we look long range the bond program and what we do on the diversity and inclusion. But I think that as we look at this, what is helpful to me is that at some point we will be able to look at the entire spectrum, entire picture of where JPS is headed. Steve and I had sat in a meeting on the social determinants of health. This addresses that area. So I just want to say it's an outstanding report.
Thank you. Thank you.
Good point, Ralph. Anything else? Oh, sorry, Jim, go ahead. That's all right, I'm invisible. You're not, it's invincible.
I understand what you're saying. I understand it's not a sprint, it's a marathon. I guess my question is, have you defined how you get to the finish line in this marathon?
Yes, well, we've defined a strategy and a 5-year plan, if you will, of where we're going. Do we get to the end? That's what the hesitation you hear. Do we ever get to the end of this process? I think we're always growing. I think we're always learning. I think there's always something new. But in terms of our ultimate goal, to make sure that patients that come through the doors of JPS are treated with respect and that we have enough information to provide the best care, I think it's going to be an ongoing process. I don't think that we say, okay, we're going to do training for 3 years and then we'll be good for about 100 years after that. I think it's a constant process of training. So what we're focused on is putting in systems and processes, whether they be policy or educational programs that will sustain where we are. And we're also focused on assessing on an annual basis where we are, so we can make sure that if there are new things that we need to focus on, we're there.
Is your strategy to have these all be classroom environments?
No, thank you for that question. They will not always be classroom environment. It's a blended learning approach. We mentioned that we have the CBLs, well, the computer base, for some types of just basic information. There's some other areas that we're focused on. We're looking at webinars. We're looking at other ways to be interactive, particularly when you think about groups like our physicians and others who are very limited with time. We are looking at what other ways to get that information across.
The next question is going to sound foolish, but we do consider this to be very important, right?
I'm sorry.
Consider what?
We consider this to be very important, right?
Yes.
I had 3,500 people working for me, and although they weren't in the business of health care per se, one of the things I learned is that if you don't communicate to your employees what's important, then they won't think it's important. So I'm not sure how you're going to reach out, but one of the things I would suggest to you, and I agree, if you just, put a bunch of charts out on the computer, that everybody will hit the button, zippy, 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 and be done with it. But if you were to videotape your classrooms and then put those out so that an employee at their own leisure could go look at that, you've got a better way to maximize the exposure.
Thank you.
Good point.
And we have taped all the sessions that we have. So that is one of the things that we've talked about, working with our communications department to have a library of subjects or topics for those that could not attend. So thank you for that. Appreciate it.
Any other questions for Michelle? Michelle, thank you for what you do
Thank you.
here. And, a lot of y'all, we talk about all the things this lady does inside the building and on the campuses. I also want to thank her. Recently, I was at a Metropolitan Black Chamber of Commerce function, the Hispanic Chamber. This lady goes all over. So, Michelle, thank you very much for what you do. And all those meetings are not 9 to 5. They're in the evenings, Saturdays, and all kinds of things. So thank you for what you do. Dorothy, thank you for the committee. It's obviously been a focus of this board and your committee. And I think we're looking forward, Michelle, for more 300, 3,000, whatever it is. It is the goal of this organization to implement that philosophy. So anyway, any other questions? If not, we'd move to item number 10 on the agenda. And I think Bill's going to cover this one. Bill?
Thank you, sir. It was a very short 5 weeks ago that I brought forward to this board a request to modernize the parking garage elevators, 22 and 23. And it was that very week that we had received from the state the authorization to reopen 29. And I think all of you know the undue burden that the closure of those 3 elevators has had on this organization. So normally, we would bring this to Finance Committee, and Finance would further that to the board, but these aren't normal times when we're talking about elevators. So I have before you a request for a combined total of $1,287,000 to modernize elevators 29, 30, and 31. And I think that you've got a contract that was sent out Monday. Apologize for that not being able to be disseminated last week, but we were working on that up until Monday.
And
So-
I might say too, I said the email you received that it was, that you indicated from Suzanne that it was a work in progress in our office, and I will tell you that we did complete that on Monday, and there have been no changes in that contract that got posted to the your website, so.
Bill,
I will say that Southwest Elevator and Tom Cavender Robert has worked very closely and been available when we needed contracts and needed to get them done quickly to meet a deadline for financing.
Well, he has, and there's a significant timeline involved with ordering the equipment, ordering the parts, completing the modernization, and historically, The previous company that we worked with was a 3 to 4 month modernization per car. And I discussed that with Tom.
Per car. Yes, sir.
Per car. I discussed that with Tom, and he said, do you want to modernize all of them? I said, well, of course we do. He said, you tell me to do it, we'll do it. So he's going to bring crews in, and we're going to work concurrently to the extent that we can, and hopefully complete all 5 of these cars by the end of the year. I
Bill,
think that's phenomenal.
I don't, oh, sorry, go ahead, Chuck. By the end of the year. My intent, what I'm saying here is not to disagree with you, but no apology is needed. We all know the significance of making sure these elevators are taken care of. You worked very hard and diligent with Robert, with Southwest, with legal. Correct me, but I think we heard about this just last week, because I believe DT and Chuck and I were in a meeting, as I have them serve on an executive committee with me.
Right.
And you brought it in there. There was no hesitation on any of our part if it involves the safety of our patients or the ability to get to the services of this hospital. My comment was, I think the board is in a position, let's take this to the board. So again, Bill, no apologies needed. You expedited this as quick as possible, and that's why it's before the board today. Is it outside the expense factor and where we're going to take it out of capital improvement? All those things can be worked out through finance, and Steve's well aware of those things. But the question is, these elevators need to be fixed.
They do.
Correct me also, they're in these elevators, I've ridden every elevator in this hospital. I believe these are in the purple bank.
They are.
They're in the same purple bank. Let's be realistic here. We don't, my feeling as chair of this board, we didn't do anything, delay anything to get those elevators in tip-top condition. So that's why it's before the board today. So Bill, again, you did everything you could do.
These elevators have been closed since January 20th.
They correct. So again.
I could show you an elevator or two that you have not been in.
Well, I'd probably get lost, because I got lost trying to find
probably
some of the
right,
building
Chuck.
way down in the back.
They're working.
But anyway, Bill, point made, it's certainly for the board to do, Ralph.
Just one question. What's before us now, is this additional to the contract we already voted upon?
Correct.
Yes, the contract you voted on initially, Ralph, was elevators 22 and 23. This is 29, 30, and 31. So in effect, you'll have 5 elevators that are going, that are under, in the contracts with, obviously with, aside from the business terms, and because you're dealing with 3 elevators as opposed to 2 elevators, it certainly makes it different, but they're almost identical, so.
Pastor, what you voted on in the contract before were the garage elevators.
Correct.
Because that's what we knew we needed, and that's what we had the parts for. Unfortunately, the previous company had received those parts, but hadn't done any work since September.
August of 18.
August of 18. So we quickly moved forward with that. Now we have the opportunity to take 3 more elevators, the purple elevators, and do that all in 1 year. And if the board so chooses to do this, I think it'll make an incredible statement to this organization, to our employees that have to ride those elevators, and to our patients that have to be transported, because our reliance now on 3, is it
4? It's 4 green elevators.
4
Yes,
green
Calvin
elevators. I was going to say red, but they're green. The reliance upon those has been a real challenge. So this will open up those elevators, and again, it's quite a statement to our team here.
These have been shut down, correct me, since January?
January 20th.
20, yeah.
Question, Bill, I was reading their correction of work. My question is this: is this contractor supposed to build and deploy the preventive maintenance program, or is that something we do in-house as a result of their effort being completed?
We have a
No,
separate.
we have the preventive maintenance contract.
Well,
with
we have a
Southwest
separate
Elevator.
maintenance contract that
But not
covers
with
not
them.
only current elevators, but those that are added to
Yeah.
or improved.
That's
yeah.
our new provider.
They maintain everything.
The very first contract we entered with, approved with SW Elevators was on the maintenance.
Okay. So they'll be
and
building a
that-
preventive maintenance program for us.
Absolutely, and they are.
Yes, sir.
And they have been.
They're on board, and that went hand in hand with terminating the current provider.
Thank you.
This is physically putting 3 elevators back in service, been out of, and they're highly used elevators.
Yes.
I'm sorry, Ralph.
I'm not trying to delay this.
Go ahead.
But what we have before us today is that we're being asked to approve the cost for elevators 29, 30, and 31 to be repaired.
Modernized.
Modernized.
Or modernized?
No, not repaired.
Okay.
Every component except a few things, the car, things like that.
The
would be
mechanical part of
replaced.
it's going to be state of the
We're
art.
not patching, we are basically.
We're not repairing, we're
yes.
modernizing.
I'm there, but I'm gonna tell you why I'm asking, because you might think it's minor. Because when we approved the contract for Southwest, we said that they complied with the MBE, This says goods and services on this is excluded, so I don't, I'm.
That's a mistake on my office's part.
Yeah, it's
That's
the
not-
same company, same.
It's the same. I apologize, okay?
All right.
Yeah, yeah, it's the same one.
It's the same one, okay?
All right.
And again, it's not been our intent, and over the years, we'll prove that we don't just pop up with something, but I think the elevator issue in this district, the fact that we need to be servicing not only our patients, but our employees, I think the quicker we can get, and again, we're not patching, they're being modernized. And you can read all the studies that's gone out there and all the art. We are modernizing those elevators to be used by our patients, their family members, and our employees. And that's what we're doing, Bill. Thank you.
Yes, sir.
Thanks for your work. Again, that's why we brought it straight to the board. Any delay, I just don't know is in the best interest of this district. I have a motion by Mr.
And
Montgomery.
Mr. Chairman, for you, that motion, Mr. Montgomery needs to have two components. One, you're approving an exception to the bid as well as approving the contract.
Please note that in my motion.
The exceptions being noted in Mr. Montgomery's motion. I have a motion. I have a second by Mr. D.T. Wynn. All those in favor say aye. Opposed, no. Thank y'all very much. Bill, thank you.
Glad you bypassed that damn finance.
Well, it would just been slick and come right through if it'd gone through finance. Item number 11 is consent. All that was provided to you previously, portal and all that. We're certainly open for discussion and/or removal of any of the items. If there are none, and there is no discussion, I'd entertain a motion approval of the consent agenda as item number 11. I have a motion by Mr. Zimmerman, seconded by Reverend Emerson. All those in favor say aye. Thank you very much. Item number 12. Okay.
Which number?
I think it was the one on.
Is it E?
What did you say?
He has to
He
abstain.
needs to abstain due to
Vicient?
any potential
On the
conflict.
Vicient contract, DT, okay.
Okay, DT.
Item E, okay.
Commissioner,
Item E,
E,
Vicient.
Mr. Wynn will abstain from
He
E.
abstained from that one. All righty, that'll take us down to legal, which I believe is the item number, which one is that?
Yeah, Mr. Chairman, I have nothing to report other than our monthly report that in April, posted to your website was a list of 34 contracts that were negotiated under $500,000. If you got any questions, call my office.
All right, thank you, Mr. Adams. If there's no other business this time in open, we should have a very short closed session.
It's all up to Dr. Schrader.
It is. So
the length of our close.
Yeah, and so my thoughts on that to those meeting, we're not going to rush you out quickly, but we're not even going to adjourn. We're going to adjourn and come right back in about 2 seconds, and unless there's something else. So thank y'all for being here today. We will take about a 3-minute break, and then we will convene and close. Get this done.
One of my lawyers did that.
All right, we will. We will now reconvene in open session at 2:45. I have before me the recommendation. Dr. Schrader, anything you need to go over, anything else? If there's no discussion, I have a motion. I have a second by Mr. Fisher. All those in favor say aye. Opposed, no. Is there any other business to come before the board? I think this is our last board meeting. This being June, we won't meet before July the 4th. So each of you have a great 4th of July with your families and all that. And there being no additional business, we stand adjourned. Thank y'all.